Good afternoon. I'm going to be speaking about the care of adults with sickle cell disease. And I want to just briefly summarize, first of all, the problems that can be encountered in the care of both children and adults with sickle cell disease in these four categories, namely problems related to the anemia, problems related to infection, then patients experience acute organ damage during certain types of sickle cell crisis. That can often be something that's reversible. But then with cumulative damage, as the years go by, there can also be chronic irreversible organ damage that contributes to the challenges that we have in the care of our patients. This slide, I hope you can see it reasonably well, summarizes some of the manifestations of sickle cell, both acute and chronic, and lists a lot of the complications that can occur. And as you read through this slide, especially as you get towards the bottom and you see the accumulation of years of dealing with this disorder, it really does raise the question, what is the hope for someone who is dealing with this devastating condition with the potential for so many acute and chronic, often life-threatening complications? What can we do to manage this? How can somebody with this disorder really deal with it? How can they even stand to go on a day-to-day basis? It looks as if there is such a mountain to climb. So here are some of the obstacles that we can dissect a little bit in terms of sorting out the needs and the challenges in sickle cell care. First of all, someone with sickle cell may actually have difficulty, especially as an adult, may actually have difficulty finding a doctor in the first place. Somebody who's knowledgeable about sickle cell disease. So generally speaking, we recognize that there is a lack of hematologists, and this truly is a blood disorder, who have a lot of expertise in the care of adults with sickle cell. And so we may need to engage primary providers in the care of our patients. Those primary providers may feel that they are not sufficiently knowledgeable about sickle cell to be able to care adequately for a patient. And so someone with sickle cell who's relying on their primary provider may find that there is hesitation to really take on certain aspects of their care. This in turn can lead to too much reliance on emergency departments for care. So adults with sickle cell disease not uncommonly go to the emergency department when they have an acute problem. But in between those acute problems, they're not necessarily getting the care that they need. Another thing that can happen is that there is perhaps a disproportionate amount of focusing on pain management in sickle cell. As healthcare providers, when we think about sickle cell disease, we often think about the challenges that are associated with managing pain, both acute and chronic, but that may sort of distract us from some of the other issues that are at hand. On the patient side, there may be issues with organ damage that are developing over a period of time, but they're not really being followed or identified, because if the person with sickle cell happens to be someone who doesn't have very frequent painful episodes or vaso-occlusive crises, they may not be seeing a healthcare provider on a regular basis. So this means that other complications of sickle cell may not be addressed until they present at quite a late stage. I've certainly seen patients who don't have many painful episodes who finally come in and they're in the very late stages of renal failure or pulmonary hypertension because they weren't being followed on a regular basis. Fortunately, and this is perhaps a good thing, our sickle cell population is getting older. And this is because of care in childhood with early diagnosis, immunizations, prophylactic penicillin, transfusion therapy for patients who are at risk for stroke and who've had stroke, better supportive care with antibiotics and transfusions as patients get older. So we are seeing patients with sickle cell whose life expectancy is gradually increasing, and with that comes the comorbidities not only of the sickle cell itself, but we have to start thinking about some of the conditions that affect any population as they get older. High blood pressure, vascular disease from diabetes or elevated cholesterol, increased cancer risk in an older population, and so on. These are all things that may occur in somebody with sickle cell as they get older as well. I'm going to begin now with a case presentation, and we're going to follow a patient from early adulthood as they progress through some of the challenges and complications that may occur in somebody with sickle cell disease. So I'm going to talk a little bit about an 18-year-old woman with hemoglobin SS disease who was admitted to the hematology service with bone pain, generalized bone pain, fever, hypoxemia, and pulmonary infiltrates. And this was the patient's first hospitalization on the adult inpatient service, before ever having actually managed to get to the adult outpatient clinic. She was treated initially for an acute vaso-occlusive episode with intravenous fluids, oxygen, morphine, and antibiotics. But then things progressed, the hypoxemia worsened, it was recognized that she had pulmonary infiltrates, and she was diagnosed with acute chest syndrome. Appropriately at that point, she underwent an emergency red cell exchange transfusion. So following the transfusion, her condition stabilized, she improved gradually, and she was able to be discharged from the hospital after a stay of about 10 days. So let's just look at the major acute problems facing that young lady. So things that needed to be addressed acutely during that admission were the possibility of an infection, a painful, very painful acute vaso-occlusive episode, acute chest syndrome, which can be a potentially life-threatening complication, need for transfusion, going through the trauma of an emergency red cell exchange transfusion, and at the same time, this young lady is dealing with transition to the adult service, out of the environment, the inpatient environment that she's been accustomed to as a child and an adolescent, and being thrown into the adult inpatient service without a lot of support, which can be by itself quite a traumatic experience for a young adult with sickle cell disease. So already we can see that this is a young lady on the verge of adulthood who is facing quite a difficult path. So the sort of things that we can offer immediately to help this young woman are, first of all, a multidisciplinary team. Knowing that care of sickle cell disease doesn't just involve the hematologist or the primary physician. It clearly does involve a knowledgeable physician in the care of this patient, but there are many other aspects of the patient's care that need to be addressed. Improved supportive care, which over the last couple of decades, as I've mentioned, has advanced a great deal. a better understanding of the pathophysiology of sickle cell. And as this whole story unfolds, I hope I'll be able to show you how research on the pathophysiology of sickle cell disease is translating into improved care for our patients. In particular, we have a lot of potential new drugs on the horizon that look as if they will have efficacy in the management of these patients. So the causes of mortality, things that we need to worry about immediately in this patient who may not even recognize how sick she really is, are the infection, acute organ dysfunction, in this situation particularly the lungs, and if we aren't careful, she may come out of this hospitalization with some vestiges of chronic irreversible organ damage. Lung damage could be permanent after an episode of acute chest syndrome with drugs, radiographic contrast, changes in vital signs, low oxygen levels. There could be some risk, particularly of kidney damage in a hospitalization like this. And so very close attention to the care of this patient, recognizing what a critical situation this is, can be extremely important. Just a few more words about acute chest syndrome. This is a frequent cause of death in children and adults. Its highest rate is in young children, but it is definitely a complication that is seen quite frequently in adults. And it's defined by a new infiltrate on the chest X-ray in conjunction with fever, dyspnea, hypoxemia, chest pain, any variation of those components, and sometimes does not present specifically with respiratory symptoms, but patients may have severe generalized vaso-occlusive pain in addition to hypoxemia, and it may take some experience in managing this disorder to recognize it in its early stages. Frequent episodes of chest syndrome are associated with a poorer prognosis in sickle cell, and people who've had an episode of chest syndrome are at greater risk for recurrence. Acute chest syndrome is considered to be one of the sickle cell emergencies. So supportive care is initiated at first with adequate fluids, adequate treatment of pain, oxygen supplementation. We usually cover patients with broad spectrum antibiotics because it can be difficult to sort out what component of the presentation is due to infection. And then exchange transfusion is used emergently for patients who have more than one lobe involved, who have hypoxemia, who appear to be clinically very acute and having progressive deterioration. A simple transfusion, by which I mean just transfusing the patient without removing any of their sickle cell red blood cells early on in the course, can also help to stabilize the situation. So in this particular patient, transfusion was a very important component of her management and directly led to stabilization of her clinical situation. And one of the aspects of sickle cell care that has advanced substantially in recent years has been transfusion support. At the same time, because of more extensive use of transfusion support in patients with sickle cell, we recognize that there are complications such as iron overload or alloimmunization, so that antibody reactions to red blood cells in these patients that have become more frequent and again require monitoring and treatment. So transfusion in sickle cell disease is a therapy that can very rapidly improve the oxygen carrying capacity of the red blood cells by increasing the circulating hemoglobin levels. So I've mentioned patients with sickle cell disease, as you know, are often anemic. and they may have symptoms from a very low hemoglobin, so that can be improved on a very acute basis by administering a transfusion. An exchange transfusion is something that can replace abnormal sickle cells with normal red blood cells, improving the circulation of blood to the tissues. And at the same time, transfusion up to a near normal level can slow down the bone marrow in a patient with sickle cell disease, so that the bone marrow is not on overdrive and it's producing fewer of the abnormal sickle cells that are released into the circulation. So suppression of the bone marrow drive by transfusion can also be a useful tool in treatment. As I've mentioned, procedures for transfusion include what we call simple transfusion. So that means the patient has a hemoglobin of 6. We give 2 units of blood. The resultant hemoglobin is 8 grams. So that's just a simple transfusion. Exchange transfusion by erythrocytophoresis or automated red cell exchange, and I'll go over that in a little bit more detail, is a procedure whereby we're taking out a lot of the sickle cells and replacing them with normal red blood cells. Manual exchange transfusion is where red blood cells are removed at the bedside by therapeutic phlebotomy, and then red blood cells are subsequently, normal red blood cells are subsequently transfused back into the patient. That is a procedure that can be performed if an automated red cell exchange is not something that is available. It's quite a labor-intensive procedure. I've done it on 1 or 2 occasions. There are protocols for providing instructions on exactly how to do it, how much red blood cell volume to remove, how many red cells to replace, but it is a quite complicated procedure, and it's hard on the patient. It's something that's really rather difficult for a patient to tolerate, and it really requires them to have quite good peripheral venous access, which a lot of our adult patients do not have. Automated red cell exchange transfusion is a procedure that's available at many medical centers now, and is a swifter, more complete, and overall more comfortable procedure for the patient. It can provide a rapid reduction in the level of hemoglobin S. By doing automated red cell exchange, where the patient's red cells are removed at the same time as good red blood cells are used to replace, it avoids fluid overload. So it can be controlled quite precisely to avoid increased whole blood viscosity by avoiding a situation where the patient's hemoglobin goes up too high. It also helps to minimize iron overload because you're removing red blood cells as well as replacing them. It does require adequate intravenous access, and it requires, for a typical adult, about 8 to 10 units of red blood cells. The indications for red cell exchange, chest syndrome is certainly one that I've mentioned. Acute stroke is another sickle cell emergency where we use exchange. Multi-organ system failure. Acute liver crisis is basically another way of describing right upper quadrant syndrome. And priapism is also, acute prolonged priapism is also another situation where red cell exchange has been employed. So we do this by using an apheresis machine which separates plasma from the cells. And this machine can replace the patient's red cells on an ml for ml basis with normal cells. It minimizes fluid shifts and blood pressure variations, so even an acutely ill patient can often tolerate this procedure. And as I've mentioned, it requires the blood bank to be able to provide 8 to 10 units of compatible blood for the patient. So this can be done on an emergent basis to stabilize a patient in an acute situation. It's also something that can be accomplished electively for certain clinical situations. So patients who have a history of stroke can be treated with exchange followed by periodic simple transfusions, or exchange transfusions could be performed and might be more effective in maintaining a normal complement of red blood cells for the patient. So it can be done as frequently as every 4 weeks in certain individualized situations. So because the patients often don't have very sturdy venous access, it often requires initially placement of something like a dialysis catheter, which can be performed either by a critical care physician or an interventional radiologist. This catheter has 2 lumens, and 1 lumen will remove the red cells, and then transfused blood enters simultaneously through the other lumen. This is just a picture of what the whole setup looks like. Here's a patient who's going through an automated red cell exchange at the present time. And so the goals of doing a red blood cell exchange are to provide, at the conclusion of the procedure, a hemoglobin S level of less than 30%. So basically what we're trying to do with this procedure is we are temporarily trying to convert the patient into somebody with sickle cell trait. But at the same time, we don't want to end up with a hemoglobin that is excessively high, because that can increase the whole blood viscosity. So we usually aim for a hemoglobin actually of around 10 to 11, a hemoglobin S level of less than 30%. So that means hemoglobin A, or normal hemoglobin, is going to be around 70 to 80%. The increased hemoglobin A has improved oxygen capacity and improved viscosity for circulating and providing perfusion to the tissues. So that's a procedure that can halt the progression of an acute life-threatening process, can help electively to maintain a patient who has a very complicated history with recurrent stroke or history of recurrent chest syndrome. Other uses of transfusions include patients who need to undergo surgery, patients who are having elective surgery should probably go into the operation with a hemoglobin of around 10 grams per deciliter. So simple transfusion has been shown to benefit patients and reduce postoperative complications in order to raise the hemoglobin level to about 10 grams per deciliter before the operation. For major surgeries, one can consider exchange transfusion. And I think in an adult who has a history of complications, episodes of sickle cell crisis, who's undergoing major surgery like hip replacement surgery, for instance, or something as major as open heart surgery for valve replacement might be another example. That would certainly be a situation where we would almost certainly consider an elective exchange transfusion so that we can send the patient into the operating room in as good general condition from the standpoint of their sickle cell disease as possible. So let's just go back to our patient here for a little while. So once she recovered from this episode of chest syndrome, she did begin to be seen on a regular basis in the adult hematology clinic. but she was requiring quite frequent hospitalizations for vaso-occlusive episodes. So now we have a young adult patient who's had an episode of chest syndrome and who is requiring frequent admissions for vaso-occlusive episodes, possibly at least as frequently as every couple of months. And so that is a situation where we would discuss with an adult patient the possibility of taking hydroxyurea if it's not something that they've already been taking. At that time, our patient was quite reluctant to take hydroxyurea. It was a difficult therapy for her to understand, and she was very fearful about the possibility of side effects. And in particular, when explaining the use of hydroxyurea and the potential for long-term side effects, we've often found that fear of long-term bone marrow complications, like the development of leukemia in someone with sickle cell disease, even though there hasn't been evidence that that has occurred, the mention of those sorts of complications has sometimes overshadowed the potential benefits of the drug, and people have been afraid to start treatment. And so in the case of this particular patient, fear of the possible unknown complications of hydroxyurea and some difficulty understanding what the benefits might be led to reluctance to begin taking treatment. In fact, she did start taking it on a number of occasions, but usually didn't take it on a consistent basis for more than a couple of weeks before she became afraid of possible complications and stopped taking it. On the other hand, this is a patient who also had symptomatic anemia on a number of admissions, and transfusion support became increasingly difficult because of alloimmunization. And so that brings me to a little bit of discussion about the adverse effects of transfusions in our adult patients, including alloimmunization. So these include, so when we transfuse somebody with sickle cell disease, these are some of the things we have to consider: non-hemolytic transfusion reactions, delayed hemolytic transfusion reactions, which is a complication of alloimmunization, virus transmission, namely hepatitis and HIV, although these are complications that have diminished to extremely small risks or likelihoods because of the advances that have been made in blood banking and testing for these viruses. Volume overload can be a concern even in a young adult patient. It's possible to induce transfusion-associated volume overload and precipitate an episode of congestive heart failure. Iron overload, as I've mentioned, when somebody is transfused on a repeated basis and their anemia is not from blood loss, it means that their red blood cells are broken down eventually, and the iron from those red blood cells tends to be stored and it will accumulate in the tissues. This is quite a problem for a number of patients with hemoglobinopathies who are transfused on a fairly frequent basis or transfused on several different occasions throughout their lifetime. And then alloimmunization, the development of antibodies to the transfused red blood cells. It's been recognized that alloimmunization to red cells occurs in about 25% of transfused patients with sickle cell disease, and this is higher than in the general population. It's thought that this is largely related to racial differences between the donor population and patients with sickle cell disease. So many donors are of Caucasian origin, but people with sickle cell disease typically are African American, and so there are differences in the makeup of the red blood cells and the antigenicity of the red blood cells. Other factors that may play a part in this are the frequency or the number of units transfused. So somebody with sickle cell disease may simply be transfused more frequently and over their lifetime with more units of red blood cells than with somebody who's transfused with another disorder. How closely the blood bank on a routine basis tries to match the red blood cells between the donor and the recipient can be a factor. So at hospitals where a lot of patients with sickle cell are cared for, the blood bank typically has a protocol where they will type the red blood cells more specifically than smaller hospitals perhaps, where their routine cross-matching doesn't involve that sort of detailed typing. Age at first transfusion could also be a factor. So younger age at the time of first transfusion may also play into the development of these alloantibodies. This table can just show you that there are some recognized differences in blood typing between different ethnicities. And strategies to prevent alloimmunization are to try and do more detailed matching. If the blood bank knows that they are typing blood for somebody with sickle cell, they can have a protocol where they type for more red blood cell antigens than if they are doing a routine cross-match. Additionally, we know that somebody who develops an antibody or more than one antibody to red blood cells is likely to develop other antibodies as well, so that as soon as a patient is identified to have developed one antibody, then that person can be identified to the blood bank as somebody who always needs to be cross-matched in more detail for future transfusions. In the very recent past, something else that has come to light to assist with this particular situation. So on the one hand, we want to be able to use more transfusion therapy to support our patients with sickle cell disease. On the other hand, we're faced with the issue that this could lead to greater problems with alloimmunization. But recent developments have revealed the fact that there is some more detailed genetic typing that can be performed that shows that even among people with sickle cell, where it looks as though the red cells are compatible, there may be genetic differences that are causing more subtle changes in the red cell antigens that are then leading to the development of alloantibodies against those red blood cells. Particularly, Rh variants are influenced, it's been discovered, by genetic mutations. And so it's now being shown that routine serological testing between a donor and a recipient in the blood bank may not be sufficient to demonstrate differences between those red blood cells, but that genotyping of donors and recipients may help to match the red blood cells more closely. And that although this is something that is largely available in reference labs at the present time, there is technology being developed to make this a procedure that could be done fairly rapidly and relatively easily by routine hospital blood banks as well, and that might make it possible to do this sort of genetic testing on a more regular basis. Now back to our patient. So for some time, she's been established in the hematology clinic. She's been in and out of the hospital, and she is married and has very much wanted to have a child, and so presents to the clinic pregnant with her first child. and is followed throughout her pregnancy in the hematology clinic. This is another situation in the life of a young woman with sickle cell disease that can lead to its own set of complications. But again, I think it's a situation where better supportive care in recent years has made it possible for young women, even with homozygous sickle cell disease, to have children safely and successfully. Our patient did have a complicated course, particularly during the 3rd trimester, and postpartum, she developed increased severity of vaso-occlusive episodes. She had thrombosis, she developed osteomyelitis, and for about 6 months after she actually had her baby, her periods of hospitalizations intensified, and she was quite ill with a number of difficult complications, but eventually things did settle down, and by about 6 months postpartum, we could see that, that things were returning to her previous baseline. So the incidence of complications of pregnancy in women with sickle cell disorders is increased. Things like intrauterine growth retardation, stillbirth and miscarriage, premature delivery, and placental abruption and eclampsia, these are all things that occur with increased frequency in women with sickle cell disease. Thrombophlebitis, infections can also be increased. But the incidence of the complications of sickle cell is also increased. So the sickle cell complications are increased by the pregnancy, and the pregnancy complications are increased by the sickle cell. Young women who are pregnant may experience more vaso-occlusive episodes, as was definitely seen in our patient, increased risk of acute chest syndrome, liver complications, acute anemia, acute neurological events, and infection. Transfusion support again comes into play in a patient with sickle cell disease in this situation. But the best way to support a pregnant woman through transfusion is not clearly established. Exchange transfusion is something that has been used in emergency situations in pregnant women with sickle cell disease, but this is not established standard of care. And in fact, there's still some uncertainty about the best hemoglobin level, the best way to support a woman during pregnancy with transfusion. As with the surgery patients, I think the best way to do that is probably to maintain a hemoglobin of at least 9 throughout the pregnancy, and otherwise to use some judgment about when a patient should be transfused. And so this is an area that still does require some research. But it's also an area where it's quite difficult to study patients prospectively. So coming back to our patient here, let me just sort of summarize the situation. Again, some of the complications that she's experienced. She's at this point dealing with frequent vaso-occlusive episodes. Her pregnancy was complicated by thrombophlebitis, and she's had some need for anticoagulation. Her transfusion needs have been such that she has developed some evidence of iron overload. We've seen some decline in organ function with elevated liver enzymes, change in her kidney function. Now she's often requiring oxygen supplementation. These things are compounded by depression and anxiety, but on top of this now, she has parental responsibilities because she has a young child, and so she has greater concerns about her own health and longevity. She's now caring for a child. So again, these are things that have transpired in this patient over the course of a couple of decades. And so during that period of time, things have continued to advance with sickle cell care that can provide her with hope for her future. Again, greater recognition that multidisciplinary care plays a role in these patients. Now we have even longer-term results of hydroxyurea studies indicating the benefits of taking hydroxyurea and long-term safety of the drug. New drug research for management of acute vaso-occlusive episodes and long-term complications. Iron chelation therapy. This is a patient who would never have been able to take desferrioxamine subcutaneously or parenterally at home. That's a challenge that would have been too much for her to undertake. But now we have something that she can take by mouth that will help to chelate iron. And so this problem with iron overload is also something that she can address. Close monitoring of end organ function is increasingly recognized as being important in her care. And not last but not least, perhaps a support group is extremely important in helping her through the challenges that she faces. So now at last she is comfortable agreeing to start treatment with hydroxyurea, and fortunately finding that there is benefit to taking the drug with decreased vaso-occlusive episodes, improved baseline hemoglobin, decreased need for transfusions. She's also able to take an oral iron chelator, so the effects of iron overload that have accumulated during the course of her previous years when she's needed frequent transfusions, these begin to diminish. And we start to begin to see some improvement even in the compromise of her end organ function that she was starting to accumulate. The sickle cell care team for an adult patient can include all or any of these components: physician, nurse, social worker, counselor, physical therapist, nutritionist, lab personnel, other specialists, and a patient advocacy group, such as we're fortunate to have here with the Martin Center. So our patient began taking hydroxyurea. After about 1 or 2 months, even, there was an increase in her baseline hemoglobin level and a decrease in the need for treatment of vaso-occlusive episodes, which she herself was able to appreciate quite quickly. This then encouraged her to continue taking therapy and proceed with some dose escalation. Also, as I've mentioned, her iron overload can be addressed because she's now comfortable taking oral therapy for that. I'm going to move fairly quickly through the next few slides, just in the interests of time. Patients can take oral iron replacement now with deferricirox, which is available, and we monitor them on a yearly basis with eye exams and hearing tests. We also follow them with renal tests, monitoring of urinary protein, and of course, monitoring of ferritin levels. I'll move through the next slides. So she's comfortable taking hydroxyurea, now with some increased confidence in the availability of drug therapy to improve the course of sickle cell disease. It may be possible for her to consider taking additional drug therapies in the future. New drug therapies for sickle cell disease include not only hydroxyurea that can induce an increased hemoglobin F level, but because of the advances in the knowledge of the pathophysiology of sickle cell disease, other drugs are being developed with different mechanisms of action. There is understanding now that the sickle cell process is very, very complex, that it involves inflammatory responses, adhesion molecules in the circulation, leukocytes, platelets, vasoconstriction. These are all components of what we recognize as the sickle cell crisis or the microvascular occlusion that occurs in sickle cell disease. And so drugs are being developed to try and target these different components of the pathophysiology of sickle cell disease. So hydroxyurea, it's been recognized, not only increases hemoglobin F levels, but has other beneficial effects on reducing adhesion proteins, increasing nitric oxide, which helps to increase vasodilatation rather than vasoconstriction, improving the chemical balance in the pulmonary circulation. And other hemoglobin F inducing agents are also in experimental stages. If you go to the clinicaltrials.gov website and you look at the drug trials that are available for research in clinical research in sickle cell disease, you'll see that there are a large number of agents that are in clinical trials or have been in trials that are completed and now being analyzed. I'll just mention CELG1 is an agent, an anti-adhesion agent that's listed on this slide. There is an ongoing study with this drug, which is being used in treatment in acute sickle cell crisis to try and reduce the severity and duration of a sickle cell crisis. At IHTC, that is a study that we will be participating in as a study site. So there is now quite a long list of drugs that we hope will be used in some way, shape, or form, perhaps in combination for patients with sickle cell disease. So what of cures for sickle cell disease? At the present time, bone marrow transplantation is the only therapy that offers a cure for sickle cell. Gene therapy is also an approach that's being researched. It's not something that's reached the level of being clinically applicable. Bone marrow transplantation has been used more frequently in children with sickle cell disease, and in adults, overall the number of adults who have been transplanted is really quite small. But again, there is optimism that this is an approach that could and should be evaluated more frequently for adults with sickle cell disease. It's most likely to be successful in a young adult who has an HLA identical sibling donor in the family. And many of our patients, including the patient that I've presented to you during this talk, do not have a family member who is an HLA identical donor. However, there has been some fairly limited at the moment success reported using haploidentical family donors in adults with sickle cell disease. So that's a donor who's a parent or a sibling who maybe is only a half match for the patient. But there are some conditioning regimens that have been quite well tolerated, and a lot of interest in what we call non-myeloablative bone marrow transplants, where we don't try to completely wipe out the patient's bone marrow, but hope that there will be engraftment of enough donor marrow that it can improve the situation and the hematologic status of the patient with sickle cell disease. and I'll just move on now to the conclusion. So just to finish up, the life expectancy of sickle cell patients has improved. Progress is being made in many areas with management of acute complications, transfusion therapy, iron overload, and treatment with hydroxyurea. We are experiencing an era where there is a better understanding of the pathophysiology, progress with novel drug treatments, the possibility of combination therapy, as well as advances in stem cell transplant, and some potential for gene therapy in the future. Thank you. Yes.
How is she doing now?
How
old is she now?
So the patient I presented is about 40, and is now has been on hydroxyurea for about a year, and has had a definite decrease in need for transfusions. I would say it's made a dramatic difference to the patient's course. So we're still sort of in the process of gradually escalating doses, but we've seen quite a marked decrease in need for transfusions, and quite a decrease in number of hospitalizations.
I've got a question on the volume overload. How is that monitored, and if it's found that there is an overload, how is it treated?
Okay, that's volume overload is something that I mentioned that can occur during transfusion. So if a patient with sickle cell who's anemic is transfused too rapidly in an attempt to raise their hemoglobin quickly, then that can cause them to have an episode of congestive heart failure. That's often recognized clinically. There's a decrease in the patient's oxygen level. They have symptoms of shortness of breath. There are changes that are quite easy to recognize just by physical examination, as well as chest x-ray. Typically it responds to, if this is something that's occurring in a hospital setting in somebody who's being transfused, typically it responds quite quickly to slowing the transfusion and just giving the patient diuretic therapy, like a medication that causes them to have a brisk increase in their urine output. So they receive oxygen, they get intravenous medication that causes a rapid increase in urine output, and a slowing of the transfusion. And then that is usually something that is quite quickly reversible.
One more question. You had mentioned corded blood as a treatment or something used to help treat sickle cell anemia. Is that what I was seeing correctly?
No.
Corded blood?
No, we've seen cord blood.
Right, cord blood, I'm sorry.
That's cord blood stem cells are stem cells that can be obtained from an infant and stored and later used for a bone marrow transplant. That's not something that's being used very much, if at all, for adults, partly because it's very difficult to get enough stem cells to replace the bone marrow in an adult from infant cord blood. But that is a way of obtaining the bone marrow stem cells that are needed to give to a patient during a bone marrow transplant.
Some places are using 2 cords.
Yes. So for a bigger patient, sometimes cord blood from 2 infants might be used to try and supply enough stem cells to repopulate the bone marrow in a bigger child or an adult.
Is that the only stem cell research used for sickle cell anemia? Or is there any other stem sickle cell anemia?
Scott, do you want to address that, or I can? No, it's not. It's not. It's a so you can get stem cells from a family member, like an adult family member. There is also a very large computerized registry where volunteer donors sign up to donate bone marrow, and they can be identified as potential donors through this computerized registry. In fact, there's an international registry, and so stem cells can be obtained from those donors if they are a good enough match for the patient. So there are quite a few sources for obtaining, but the stem cells are the cells that are needed to grow all the other blood cells in the bone marrow. So if you give treatment to destroy the bad bone marrow, you've got to replace it with something. And so that's what the stem cells are used for.
There's a booth outside in the hallway here from Angela with Be the Match. You can get some more information about the National Marrow Donor Registry and where you can get stem cells from for a transplant.